Thank you very much once again, Mr. Lakani. This is one case, one pearl. Some of these cases you would have already seen, but I'll try to go with a lot of patience and highlight. Now, this is the patient of Port-Petit syndrome, a 62-year-old female with double vision, right periorbital pain, and blurred vision of 6 months duration. She was diagnosed to have thyroid eye disease elsewhere and treated with IVMP and oral steroids. But after that, she developed drooping of the left eye. And she was systemically, she only had hypertension. But she had this pulsatile lesion in the neck. I hope you can see this visible pulsation. Now, the scan showed thickening, gross thickening of the right superior rectus, but not typical as that we would see in a lymphoma case or a thyroid eye disease case. But this I would still attribute that it is thyroid, because on the other side also some of the muscles were thickened. Usually it's not common to see lateral rectus, but this is all what it showed. The gross thickening of the superior rectus on the right side with some amount of other extraocular muscle thickening. So because of this pulsatile lesion, I knew we are not dealing with a straightforward case of any tumor or thyroid. So we wanted to get her systemic evaluation done. A CT aortogram was done, but there was not gross aneurysmal dilatation of the arch of aorta, which we thought would be there. But there was ectasia, that is some amount of dilatation of the brachiocephalic artery, right side, aortic arch, left common carotid, and the vertebral artery. So this, what was it causing? This was causing the irritation of the cervical sympathetic chain on the right side. And on the left side, she had developed some features of Horner syndrome. My colleagues in the endocrine department said that right now her thyroid function tests were normal and the antithyroid antibodies were also normal. But the vascular surgeon also suggested that nothing to be done for the ectasia except just change the antihypertensive medication. Neurosurgeon wanted to do a superior rectus muscle biopsy, that is before he saw the CT aortogram. So if I had done that, I might have burned my finger because I would have had severe uncontrollable bleeding on the table. So in this case, we only watched and her symptoms gradually elevated, though the pulsation didn't go off. We just told her the problems and no surgery was done on this case. So the important take-home pearl is link ophthalmological and systemic findings to the best extent possible. And this is a 43-year-old woman, the next case, protrusion of the left eye with blurred vision, and a very recent history of hypothyroid status, diabetes mellitus, hypertension, and raised serum prolactin levels. So she was having multiple endocrine dysfunction. So features suggestive of a pituitary dysfunction clinically also, because she was quite a tall lady, almost 6 foot in height, and had features of hirsutism, etc. I'm sorry, this should have come earlier. How we link systemics in thyroid cases, gross anemia, other autoimmune diseases like pernicious anemia, vitiligo, myasthenia can be seen. So this slide has come in between. Now coming back to this 43-year-old lady, she had good vision in the right side, mild blurring on the left side. Notice the thyroid swelling in the neck. Now the MRI confirmed features of the muscle thickening on both sides, slightly more on the right side. But what else did we see? Now, this particular lesion in the pituitary area, it was a sphenopetroclival lesion. So 3 bones were involved here, and the lesion was sitting here and was causing all the pituitary dysfunction due to multiple endocrine problems. So again, going back to the anatomy, a very typical area where the meningioma sits. The sphenopetroclival lesion. Now she had some amount of field changes. Now the management is, are we just going to watch this lesion because day by day her symptoms were increasing, or do we surgically excise, or just there's no chemotherapy as such for meningioma per se. But of course, a lot of talk of cyber knife and gamma knife now. Cyber knife is the mainstay, though gamma knife has also been employed. It's actually for those of you who want to just think a little more, it's nothing but a little bit of interplay and change in the LINAC, that is the linear accelerator. Some of the settings are changed. But of course, then these machines are so expensive, the treatment costs also become expensive. But for meningioma, CyberKnife is something which will stay. We don't have to do surgery because we know invariably, even if they have good vision, they will lose their vision. The chances of losing vision on the table very much is there. So in this case, the neurosurgeons felt that only a radiation would not help. Let us partially debulk some of the lesion, and the remaining part will give her radiation because it was a meningioma grade 1, and the size, according to them, was a little big. So she underwent surgery followed by radiation. Now she's on a 4-year follow-up. Initially, she had a little bit of abuse, a 4th and 6th nerve palsy because of the location and the surgery. She has residual lesion, which has been taken care of radiation. And this is her 4-year follow-up now, wherein she is doing very well and maintaining good vision in both the eyes. So once again, coming back to meningioma, where I speak about gamma knife, in such cases where a biopsy, very straightforward, this is a meningioma, the typical tramp track appearance, surrounding and encasing the bone, straight away go for a gamma knife instead of subjecting the patient for surgery. This patient only had a little bit of periorbital puffiness with a little bit of dip in vision. So this is her serial. This is February 2017, the papilledema, opticociliary shunt vessels, which we see gradual decrease after the gamma knife treatment was given, February 2018. This is August 2018. After that, she tells me she's doing well. I'm yet to see her for a follow-up, but she is maintaining 6/6 vision in her right eye. Now, after the treatment also, there will be a little residual lesion, but that can be carefully watched, because some amount of it would have already scarred. So the take-home point is, for meningioma, gamma knife is the treatment. It is available in certain centers in India, and it is worth the cost at the moment, and we hope that it can be brought down. 2-year-old male child, there's a sudden onset of proptosis after an upper respiratory tract infection, lesion closely pressing on the optic nerve, and you can see in close proximity to the nerve. This is a very cranky tumor. Many of you have already guessed it. After an upper respiratory tract infection, it likes to hug and wind around the nerve. CT scan was also done to see whether we could do an FNAC, but 2-year-old child, you will have to give GA. Then you will wonder, why not do surgery itself rather than do FNAC with its risks. So here, a course of IV steroids is given because in lymphangioma, there is certain amount of lymph inflammation. You should realize that lymph cells are not cells which are typical for the orbit. They are some kind of rest cells which are there, that is normal cells in an abnormal location. So usually inflammation triggers this tumor, and it's a very bloody and vascular tumor. So steroids were given to bring down the inflammation. Many a time, pubertal age, they get a second attack, and it increases grossly during puberty. So here, what do? Do you observe this lesion? It's pressing on the nerve there, because 1 month later, the child was still a little uncomfortable, symptomatic. And you can see the lesion has slightly actually become bigger, and it's pressing on the optic nerve. Almost half the nerve has got compressed there. So repeat a course of steroids, which is not great for a child, because again, you have to admit the child, or needle drainage, FNAC, or a surgery. In this case, we went ahead with the surgery, a lid crease approach for the superior orbit, which is my favorite. I don't like to make any brow incisions as much as possible because it leaves behind scars, and the child improved. So suspected lymphangioma, when there is sudden onset of proptosis. Of course, in the last 10 years, sclerosing agents have helped us a lot, especially bleomycin. We tried many things, picibanil, that is OK432. We tried a lot of triamcinolone. All of them have about 50%, 60%, but bleomycin, I think, is working very well. It's here to stay, except for a violent reaction. In this child, I had not yet started using, but again, we have to see the safety in children and be very careful and judicious while injecting. We partially debulk and partially, but especially when it's posteriorly located, I think the residual cyst can be taken care of with the help of a sclerosing agent, because as you know, lymphangioma cannot be removed fully. Now, this was a child, 12-year-old child with a lesion, which is we call as a triradiate lesion, and there was protrusion of the right eye, which was only recent, loss of weight, loss of appetite, feeling unwell. Now, this lesion is there. You can see it in the infratemporal fossa, lateral orbit, sitting there. Some erosion of the bone has already occurred. You must think of malignancy because of recent onset and loss of weight. But again, you have to keep everything in mind. So here, I don't think we offered any trial of any treatment straight away. She was admitted for surgery on the, and so the possible diagnosis was tuberculosis or other granulomatous lesions, a malignant lesion because of erosion of the bone. Again, TB can cause erosion of the bone, or a dermoid, which is very unlikely because the presentation was quite dramatic. Interoperatively, there was thick purulent material with granulation tissue. And of course, she turned out to be manto positive. The good thing is we already knew about gene expert test, because TB to demonstrate in the Zeal-Nielsen can be done, but many a time it's negative. Again, cultures take a long time, just like fungus, which we are all facing now. So manto test was grossly positive, but the gene expert test, which usually comes in within 48 hours, is very, very helpful. Here, you don't have to put the sample or the tissue which we take in formalin. Straight away, we subject it for the gene expert test. I think it will be available in almost all the major cities and towns in India. And she was on ATT. Then what happened? About 3 weeks later, she comes back. She was improving. She comes back with drooping on the other eye. So a little bit of the pus, which could not be drained, had trickled along the chiasm, please note, and gone to the other side. I've seen patients of my husband's who have had silicone oil trickle like this. And that too, especially if they've lost vision and on one side, this can be pretty devastating. So please keep this also in mind. And you need not waste time in doing a fields, but if you have time, you can do that. All here it needed was a little change in the combination of our anti-tuberculous treatment. And generally, ATT has to be given for a little longer time in such cases. Now, sometimes they are not so lucky. They start having a sequestrum with a discharging sinus, some amount of ulceration. When sequestrum comes, this has to be debrided, especially in tuberculosis cases. So common things common. Of course, you have to keep malignancy topmost on your mind, but a careful history and clinical evaluation and keeping other tests handy like your manto test, gene expert helps. Now, when you have cases like this, trauma, acute cases, with so superior wall fractures, bone fractures, here at least the child was conscious, but if the child is unconscious, generally the neurosurgeons would like to admit these patients in the ICU, and they are under observation because you have to worry about meningitis, whether the child will survive, throw fits, etc. This is called neuromonitoring. Generally, that time the child is not fit or the adult is not fit for general anesthesia, and we would like to observe. In this particular case, there was a fracture in the superior wall, which the neurosurgeon said need not intervene. When you have a fracture like this, look carefully for CSF rhinorrhea. And here, when you have devitalized tissues, you think there's still not much of necrosis, don't be aggressive. Just wait, be patient, and you have to observe these cases. IV steroids, antibiotics for the first 48 to 72 hours. As steroids, generally the neurosurgeons or the others and ICU specialists, internists are not forthcoming, but please request them, work closely with them. Luckily, Muker has taught us all to work closely together. And immediate surgery with consent for evisceration, please don't do that. Just wait. Once the child is stable, a week later, this is how the child improved. This is 2 weeks later and a month later. So don't be aggressive, especially with fractures in children. They behave like typical Greenstein fractures. Now, if the eye is quiet, typical diplopia, this is within 48 hours, then you know there's not much of edema, then you know you have to intervene. But please look at all the general condition, neurostatus, wait for about 1 week, 2 weeks, let all the edema subside. That's the general teaching in fractures. Then take up the patient for surgery. So it is better to be conservative. Now this dengue case, which I saw some time back, it's also been published. Now he had 5 days fever, and following which he was given platelet transfusion. Then he developed acute loss of vision, high intraocular pressure and orbital pressure could not, and he was transferred from another hospital in this state. could not retract the eyelids, highly elevated IOP, platelets were very low. It was around 7 to 8,000. He was in a delirium state, blood staining of the cornea. That was after a few days later, I noticed. So when I could take him up, about 2 days later, I could take him up under GA. But this was what I found. The cornea was fully necrosed, means it had become fully black, because blood staining itself of the cornea takes about 1 week to 2 weeks. But here it had become totally black. And I did a lateral canthotomy and cantholysis. The left eye started auto-eviscerating by then itself. So I didn't do anything much. I just held on. Right side was subsequently, he was taken up by for a PK, that is tectonic PK, but completely there was necrosis inside, white. The vitreous was white, the retina was white, the optic disc was pale, and this he had all along a bleed along the perioptic sheath. So this was another case of dengue. He was in the ICU. He had cerebral infarcts, but about 6 days later developed the eyelid edema. He had an infection. He had endogenous endophthalmitis due to dengue. Now the question arises in dengue cases, should we give a high dose of immunosuppressives? Because that same question is arising now for COVID cases. Should we give a high dose and prevent the immune reaction? Because all this is a kind of an immune reaction. Unfortunately, in this case, I had to eviscerate one side. Luckily, the other side was absolutely normal. Now, immunosuppressives can be, but the disease itself, we don't know. The other things have to improve. And in the long run only, we'll be able to say whether what happens to these immunosuppressives, how do the patients respond. Now, we see very often eyelid tumors, that is sebaceous gland carcinoma. The importance of biopsy for these cannot be overemphasized. This patient came to me sometime in 2014. About 7 or 8 years earlier, he had a tiny lesion in the lower lid, and it was biopsied, and he was told it was just something like a chronic granulomatous inflammation, and he just slept over it because he knew that this was from a very big hospital which had given him a proper biopsy report. I think sometimes this can happen, that is to all of us, that if we have to go deep, if the patient, if the doctor had gone in a little deeper, they would have found this to be a sebaceous gland carcinoma. So here you see it is almost invaded half the orbit. So what was essentially an eyelid tumor had become an orbital tumor. He was not willing to believe, he didn't want. And then we did a DE biopsy. Here you will notice that I have gone up to the bone, and it was confirmed. And then he didn't want exentration. So an excision was done under frozen section. Adjuvant chemotherapy along with radiation was given. But despite all heroic surgeries, he used to have repeated corneal inflammations because the radiation has its own side effects, radiation, corneal changes, surface changes, retinopathy, etc. And then he was, after about 5 years, this was the situation. Finally, I said, okay, he's disease-free now. Cornea is getting stable with, in between, BCL also could be used for a short while, but then it used to fall off because of the lid condition. So this was so bulky. And then I tried to do a phonics reconstruction here. And about a year later, I noticed recurrence in the superior orbit, which was absolutely free to begin it from the beginning. So now the last 2 years, I've not followed him up. But what I mean to say, it's about 11 years of utter misery with sebaceous gland carcinoma, which could have been beautifully taken care of. Now, orbital infections, you have the cellulitis, this is very common when we have sinusitis. Subperiosteal abscess starts behaving like a tight compartment syndrome. Now, when you have orbital infection, subperiosteal abscess, or even orbital cellulitis per se, please remember two important structures of the eye which have to be taken care of. One is the cornea, just like your thyroid disease. You have severe exposure keratitis. You don't want to, in addition, because of the infection, you don't want to have a corneal infection or a corneal abscess. And the next is, of course, your optic nerve, where you want to decrease the morbidity to the optic nerve and prevent optic neuritis. See, another thing is the subperiosteal abscess. Outside, the proptosis may not be very dramatic. But then sometimes with your IV antibiotics, earlier we were giving oral. If it doesn't respond, we used to give IV. But these days we know when it's quite, when the imaging shows quite a lot of involvement like this, you straight away start with IV antibiotics A combination of broad spectrum. I like to add glycosides. By day 2, I give them also steroids under cover of antibiotics with the help of a pediatrician in children and an internist in adults to decrease the morbidity to the optic nerve, to prevent optic neuritis. Because of you may beautifully clear your orbital cellulitis, but you don't want the patient lose their vision due to optic neuritis. So another thing is sometimes this abscess can just shield off and start behaving like a tumor, which is an antibioma, but it's not, it will sometimes even mimic a malignant tumor. So this slide I brought in the other day for our subspecialty. So this is diffuse cellulitis. This is a localized abscess, still has to be carefully imaged and taken care of because it can shield off and become an antibioma. This is a subperiosteal abscess, which can behave like a tight compartment. You see, it starts pushing up and starts creating morbidity to the optic nerve, though outside the proptosis may not be severe. And last but not the least, if the infection is not properly controlled, you can have cavernous sinus thrombosis, meningitis, and can even lose the patient. So why it all started with some sinusitis, which we already have. In Bangalore, 8 out of 10 patients, if you take an X-ray, will have some amount of sinusitis. So here, the best thing is to debride endoscopically. Here, the patient needed both an endoscopic debridement with an ENT surgeon plus an external cut, because sometimes if the abscess is very tense and getting shielded off with fibrous tissue, as I just mentioned, you need an external cut as well. The sinuses should be beautifully opened up along the natural passages. As much as possible, don't make external cuts except when it's absolutely essential. So here a thorough anatomy of the sinus passages is essential. Here again, most of us are orbit and oculoplastic surgeons. Why? Even many ophthalmologists across India have now started closely working with ENT surgeons. In that way, it's a win-win situation for each and every city, every town, and every hospital. But sadly, at the expense of what? Sadly, at the expense of mucor. Anyway, now sometimes midline lesions like leukemia can present as severe sinusitis and orbital abscess. Please keep this in mind. These all come under masquerade syndrome. Again, leukemia is one tumor or chloroma which likes to go along the central lines. Kasuri has a beautiful paper on chloroma, I remember. Now, mucocele, again, frontal mucocele, ethmoidal mucocele, frontoethmoidal combination mucocele. Please make sure the mucocele is drained under the natural passages, if at all one small cut. Because again, this can be very dramatic sometimes. The patient may not know they are harboring a mucocele unless they develop severe secondary infection with gross proptosis. Sometimes there can be severe lead edema. And this is a lady who had about 13 to 14 surgeries. She had about 11 elsewhere before she came. All of these had become encapsulated and loculated with thick fibrous tissue. So initially a FES was done with ENT surgeon and an external cut, but that was not enough. About 2 years later, though she wanted to avoid this, we had to do a cranial surgery, go in, debride. The ENT surgeon had to come in with the endoscope. I had to go and make another cut in the orbit to take off, and debridement was done cranio with a neurosurgeon. All the frontal sinus debris was debrided. Here again, some people like to keep it with fat, but if you can again widen the frontal recess and make a large opening so that the frontal sinus, whatever residue is there, will permanently drain. At the most, we can keep some bone graft, or at the most, we can keep a certain other material, because grafts don't work well due to infection. And sometimes there can be residual defects like this, but that can be always taken care of at the later stage. Now, this patient is on a 4-year follow-up, disease-free. A little bit, this is not the latest photo, I'm sorry. She came early this year. She has a mild proptosis, but that's about it. I would rather say it's a mild dystopia, and she's doing well. So a mucocele should not land up like this. That is the take-home message or the take-home pearl. Now again, coming back to the scourge, which we are all facing across this country. Now this is a 19-year-old boy with 600 sugar, and this was the state. He came for NLD surgery all the way from the from the Gulf, one of the Gulf country, I think Muscat. Okay. Now, what do you see here? This was the involvement. A FES was done, and then a little bit of blackish material came out. So immediately that was aborted. He was treated for mucor. Subsequently, a year later, he had underwent a DCR surgery, because DCR surgery, of course, an endoscopic DCR was done, but some amount of canalicular obstruction had also developed. So this was taken care of later. Then, of course, he lost his weight. He was weighing around 125 kilos. He lost his weight. His sugar level came down, and he beautifully managed his diabetes and his mucor. He has not had a recurrence at all in the last 11 years. This was sometime in 2010. Now, in mucor, what we would like to do ideally is to get a very good imaging done. But all these years, we have been mainly getting CT, because we do FES along with the help of a ENT surgeon. But can I please interrupt here? Can you please request Santosh to come on, please, if he is available?
I'm there already, so you can finish.
Hi, Santosh, thanks. Yeah. Go along the natural passages and debride the sinus. Now, in renal transplant patients and those who are severely immunocompromised due to severe malignancies, or the most common is diabetes, post-renal transplant patients who are on long-term steroids, in fungal cases, you may have to give a little bit of steroids also. But debriding and with this liposomal amphotericin B is a real blessing. And they may sometimes need a little longer, at least minimum 2 weeks of hospitalization with liposomal. Then you can discharge them with posaconazole. I've even given steroids, and this was one success story. Patient is fine and well. He's underwent a cataract surgery also later, about 3 years back. This is another success story where the patient was severe, very high sugars, 400, 500 sugars. Then you also notice this double density sign of the fungus. Okay, yeah. You can know, okay, it's not there in this. Here in this slide, you will see within the sphenoid sinus, a double density sign. This is almost again typical of mucor, because many a time, just like TB, mucor is not so easy to demonstrate. So again, a thorough debridement, opening of the sinus, along with liposomal amphotericin B, depending upon the clinical condition, with the local amphotericin B, you can give the lavage every once in 2 days or once in 3 days, depending. And the patient goes back with a course of antifungals if required. That has been the mantra for many, many years. But of course, we all had to face this mucor by a storm. And supposing a patient doesn't come back for proper follow-ups or really debilitated, then they start developing this eschar and eschar, which we saw in these cases also now during the scourge. And then they tend to auto-eviscerate. But if or auto-exenterate. Now, if I remember in retrospect, in the last 31 years, not had a single case where we had to exenterate, but in this case, it was almost like an exenteration where I had to debride, and most of the time it's necrotic tissue. And once you put in your endoscope, you will see this blackish material there in the middle turbinate, then you almost know it's fungus. And sometimes in the early stages, when there is a very minimal involvement, but already type 3, that is where it has gone to the brain already, where the cavernous sinus involved, you will see a complete bluish discoloration. Everything will be bluish color there. There in that case, please don't do any biopsy unless you see some necrotic tissue, because if you make a nick with an endoscope, you will have severe bleeding, uncontrollable bleeding on the table. This is one case I managed recently. I was asked in called in to exenterate, but I said, hold on, cornea is clear. Let's clean up and see. Again, here you see a double density sign here inside, beautiful double density sign. So one debridement had already been done by the ENT surgeon. Again, we undertook a 3-hour debridement, and this was a active COVID positive patient. And this is day 5. He improved very well. I did a temporary tarsophraphy there just to hold things back. Cornea cleared. He said he was also seeing light in one quadrant. And there was a little, the needle rectus was not behaving that well. But by day 11, this happened. See, he was on local ampho. Unfortunately, we didn't get liposomal because it was severe shortage. And he had side effects to that. Plus, he had some amount of intestinal involvement due to COVID. So he was also developing severe diarrhea because of the medicines, because of the intestinal involvement, but he was already a diabetic. So I can't say that the pancreas also had been involved, because we didn't do any pancreatic biopsy for him. But unfortunately, this patient, by day 13, he was lost. So what I mean to say is, I think we have to just keep everything in common, eyes open, ears open, everything open, to pick up all those telltale signs and learn from each and every case and impart what we know to others. And hopefully, I think now we will not be faced with this kind of a problem again. It's been overwhelming. I thank Santosh. I thank many of the people, those who are present here, who have seen much more cases than me and helped out in bringing out treatment protocols. With this, I end. Thank you very much. Over to Santosh.
Thank you, Lakshmi. I think you covered a lot of ground. Wonderful talk. If you have more slides, you can speak on, because we have 1.5 hours.
No, maybe I'll go in for Manisha's talk, come back.
Yeah.
And then what I will do is we can take some questions, and
Sure.
because I'm sure you will have a lot, and you also in some of your slides you have to rush sometimes because of the shortage of time. I think you can take your time and explain very well, and I'm sure there will be much more to learn from you. In fact, I don't want to miss your talk, but this was inevitable.
Sure, please come back. All right.
Yeah, thank you.
Thank you so much. Good afternoon. I'll be talking about logical approach to orbital tumors. Basically, I'll be covering the tumor part of it. Lakshmi has already covered infection, inflammation very beautifully. So I'll show you pictures as well as